concern is mounting following the discovery of a new COVID-19 variant. This new EG.5 variant has been classified by the World Health Organization as a variant of interest. It was designated the letter E in the Greek alphabet and will now be referred to as Iris or Iris. But just how worried should we be? Let's bring in Professor Mosa Moshabela, who's with the Public Health Department at the University of KwaZulu-Natal. He joins us now via our video link for more on this. Prof, lovely to see you. Thanks as always for making time for speaking to us here at Newzroom Afrika. Now, we'd always been warned since the start of the pandemic itself that COVID-19 will continue to mutate. And I suppose this is just one of those instances where that's happened. But what is it about this particular variant, do you reckon, that's caught the attention of the WHO?
Good afternoon, Ayanda, and greetings to the viewers. I think that this is something we have to come to terms with for now, that COVID-19, in as much as it is circulating at lower levels, it's still with us, and the WHO, of course, is monitoring what is happening across the world. And since, a few months ago, we saw an increase of the EG.5, mostly in Asia, and now it seems to have been picked up in a lot of other places, including the US, UK, France. And so the data from the UK recently basically showed that the variant is starting to show the kind of mutations that are concerning a particular subvariant called the EG.5.1. That's the one really the WHO is focusing on. It looks like it's got the potential to spread fast, to attach to cells effectively, and to also evade the immune system. And that's why the WHO is interested. So last month in July, they designated it a variant under monitoring. And last week on Wednesday, they decided that it's now a variant of interest.
So it spreads quicker, so that may lead to an increase in infections. But what do we know about its ability to cause severe illness?
Yeah, so at the moment, there is no evidence to show that it's actually dominating yet. It was still at about 10% in the UK data. And that's why they have not called it a variant of concern yet. But most importantly, as you say, there is currently no evidence to suggest that it's causing more severe disease. There's some uptick in hospitalization, but I think at the moment the explanation is that it's probably just due to the increasing numbers of cases, not necessarily because of severe disease. And it's got the characteristics of what we saw with Omicron. And you would remember that even with Omicron, we saw a large number of cases. But in terms of severe disease, we did not see that. So this particular variant is a subvariant of Omicron. It comes from the family tree of Omicron. And that's why at the global level, there isn't really a concern that it would cause more severe disease. But they are monitoring the data and the evidence. So far, there's no evidence of severe disease.
Yeah. That being said, what we've been told, at least over the past 2 years, when we learned more about COVID-19 and its effects, is that the faster it spreads, the more of an ability it does to to mutate. Is that the case in this particular instance? I mean, should we be worried about that?
Not necessarily. Remember, what's different now compared to back in the day is that generally we have relatively higher levels of immunity in the general population, both from the vaccine but also from infection. So the trends that we are seeing now are probably characteristic of some decline in population immunity, which is why it is able to exploit those gaps. But at the same time, those declines don't necessarily represent very low levels of population immunity. So we don't necessarily expect to see a rush in the increase in the number of cases like we saw with Delta or with Omicron because of where we are in the trajectory of the pandemic. But I don't necessarily think that there's any reason to panic, especially because the types of mutations we are seeing there show that even if it can increase in terms of spread, it is not necessarily going to cause symptoms that are characteristic of severe disease. It's still upper respiratory, the usual that we know of.
Right. You know, at the onset of the pandemic itself, there had been so many different debates and discussions about the current candidates of vaccines we had at our disposal. Part of the concerns then, potentially even now still, is that we have no way of telling how much time of immunity essentially this vaccine grants you. In other words, how effective its protective effects are. Are we any clearer about that now?
Yeah, I mean, not necessarily. I think the one thing that we are clearer about is that when we're looking at the immunity, instead of just looking at the antibodies, it is also important to also look at what we call the T cells or the cellular. They're ones that also carry more memory cells. So even if perhaps you might find some decline in antibodies, we are trusting that the backup system that we have that carries memory will be able to remember. And so even if a person can get infected, they are not necessarily going to have severe disease because it will trigger the backup, the memory cells that will then protect them from severe disease. And so since we now know a little bit more about that arm of the immune system, I think that we are a little bit more confident that going forward, because of our previous exposure to vaccines and to infections, we may fare better whenever there is sort of a spike in infections. Having said that, I think that may make sense from a general population. It does not necessarily apply, for example, to people who have specific risk factors for severe disease and people who might be vulnerable to long COVID. Those people, we don't know who they are. Those who may be vulnerable to long COVID, and the disability that comes from the post-acute infection of COVID-19 in a proportion of people who suffer long COVID is the one that I think really concerns us. In as much as we might be having a backup immune system, they may still not be protected from that. So again, it does speak to the sort of gaps in what we know for certain and what we don't know for certain. But at a general population level, I think that we are still comfortable that the level of population immunity we have, even if it might decline at some point, it may not necessarily result in the kind of spread we saw early in the pandemic when there was virtually no population immunity.
Fascinating stuff. Given then what we do know about this backup system, as you've described it, these memory cells, what becomes the advice around booster shots, at least for people who are not living with comorbidities?
Yeah, so I think that still hangs in the balance. So for people who travel a lot, like myself, I still prefer to take a booster. At least once a year I should. Because I might be exposed in different places where I travel. But those who are local, and if there's no evidence of spike in infection, it's very difficult to make an advice. It just depends really, Ayanda, on whether people are erring on the side of caution or on the side of risk. For those who are erring on the side of caution, I think that it's advisable to take a booster. But for those who prefer not to, again, we can't blame them. It's just that that choice now means that they must live with the consequences of what might come, especially long COVID. They might not have risk factors for severe disease, but we don't know who's going to get long COVID and who's not going to. So for me, I would say let's just see what the guidelines are from government on that one and the availability of vaccines. But personally, I think that those who know that they are exposed either due to travel or if they are worried about long COVID, it's better to be safer than sorry.
Yeah. Look, I'll never be forgiven, Prof, if I don't delve into this terrain. Depending on your own social media circles, for lack of a better term, people may argue differently about whether or not we're seeing more instances of adverse effects as a direct result of the vaccines themselves. I mean, the issue around the anti-vaxxer sentiment have been well documented, and I think that debate still rages on. But I wonder if science is pointing us to a particular direction, now that we've been able to study not only the vaccines for longer, but their effects for longer too.
Yeah, I think that the whole, and it's so unfortunate, that the whole debate around adverse events of vaccines is caught up a lot in politics, especially the battle between the right and the left-wing politics, not just in South Africa, but globally, especially in the US, and it affects us a lot. And we haven't really have found a very effective way of managing and dealing with misinformation and disinformation campaigns. And unfortunately, they tend to be driven a lot by people who are politically affiliated as well. So I would say that in general, we know that for the most part, the vaccines are pretty safe. I just finished a review of the South African response, and the really only data that we have where we found adverse events that were linked to vaccines was in the 2 cases that were reported by SAPRA linked to Johnson & Johnson. We don't have strong evidence suggesting that there's been any large-scale adverse events associated with the vaccines. But having said that, I think that the biggest problem has been long COVID, and this is a silent problem that people don't take notice of. It's like when people are exposed to COVID-19 and they've been vaccinated and they suffer long COVID, they are much more likely to think that it's because of the vaccine than to COVID. Some people have had COVID, they don't even know, and yet they suffer symptoms of long COVID. And I think the more people are aware of the long COVID problems, the more they are likely to actually understand that not everything is attributed to the vaccines themselves. And in fact, adverse events from vaccines are very rigorously studied compared to other problems that arise from long-term consequences of COVID infections.
Sure. Yeah, we don't know a lot about long COVID, but I mean, I think many people can describe a person they know who will explain to them that since the pandemic, they just have never been able to shake off this deep sense of fatigue. Their mental faculties are not just as sharp as they used to, and several other issues. Is there an academic or scientific definition of what long COVID entails, such that people at least are able to identify whether or not they're actually suffering from this without even knowing?
Yeah, it's very difficult because really the diagnosis of it is linked to previous exposure to COVID. And most people don't really know that they've been exposed to COVID in the general population. But if they do know, then it's not easy for them to associate it with COVID-19. But in South Africa, we have studied mostly the people that have been admitted and then discharged, and followed them up over time because of the long-term study that was done by the NICD, led by people like Wasila Jassat and them. And so we understand more about those people that have been in hospital. Those that have never been to hospital, we don't know a lot about. But what I can say is that long COVID is a multi-organ disease that may basically affect any part of the body as long as there is what we call the ACE receptors. The same ACE receptors that we spoke about at the beginning of the COVID pandemic that are in the lungs, that the virus had the affinity for, can be found in many parts of our body. So that's also why multiple parts of our body are affected by COVID-19. And we've seen that it will affect mostly the mind, the heart. It will also affect other parts of the body like the chest, and also, pretty much any part of the body, including reproductive organs. So people have had lots of problems from different organs in their body because of this process that happens after they have come out of an acute infection. And it may last for 2 years. In some people so far that have been monitored for 2 years or more, it's able to continue for that long. Some people tend to get better in time, but other people, it continues. And as you say, because of the extent to which the COVID-19 spread, you can hear a lot of people report certain symptoms, even though they may not necessarily be able to causally link them to COVID-19.
Clear and informative as usual. Professor Mosa Moshabela, thanks very much indeed for your time.